Hello and welcome to the Amplifying Scientific Innovation video podcast. I'm your host, Dr. Sophia Onoye, founder and CEO of the Sophia Consulting Firm, a life science marketing and communications consultancy that was established in New York City with the goal of amplifying scientific innovation. The goal of this podcast is to showcase scientific innovation stemming from global life science companies through conversations with senior leaders who share their unique leadership journey, corporate vision, and industry outlook. My guest today is Dr. Carmen Guerra. She's an associate professor of medicine, vice chair of diversity and inclusion in the Department of Medicine, and associate director of diversity and outreach at the Abramson Cancer Center, ACC, at the Penn School of Medicine at the University of Pennsylvania. Her research interests focus on better understanding and eliminating barriers to accessing cancer screening tests and cancer treatment clinical trials. Carmen also serves as the advisory dean of students in the Dr. Helen O. Dickens House at the Penn School of Medicine, PSOM. As if that's not impressive enough, Carmen is the founding co-director of the University of Pennsylvania Health System Colorectal Cancer Screening Navigation Program, the Penn Breast Health Initiative and Breast and Cervical Cancer Early Detection Program, and the Abramson Cancer Center Clinical Trials Ambassador Program. In addition, Dr. Guerra is the board scientific officer for the American Cancer Society's ACS National Board of Directors and a member of the ACS's Mission Outcomes Committee, Guidelines Development Committee, and National Advisory Council on Health Equity. But wait, I'm not quite done yet. For her work to help underserved patients, she received the prestigious ACS St. George National Award in 2017 and the Hospital of the University of Pennsylvania Patient Advocate Award in 2018. Dr. Guerra received her Doctor of Medicine degree from the University of Rochester and completed the Executive Leadership in Academic Medicine ELAM program in 2019. With support from the Office of Provost and in collaboration with the Wharton School of Business, Dr. Guerra led the development of a leadership training program for the women and diverse faculty at PSOM in 2015, which to date has trained over 120 faculty. I was introduced to Carmen by the amazing Bruce Levine, a Penn professor and co-inventor of the first FDA-approved gene therapy, commercially known as Kymriah, and featured guest on episode 11, season 2 of the Amplifying Scientific Innovation video podcast. I'm a huge advocate for increased representation of women and minorities in clinical trials and the life science industry at large. And it's an absolute pleasure to feature a leader as accomplished as Carmen. Welcome to the show, Carmen.
Thank you, Sophia. I'm so embarrassed about how long that introduction was. So thank you so much for the stellar job you did going through all of that. And I also want to say thank you for having this opportunity, which is, in my mind, such a wonderful opportunity to talk about such an important problem. And finally, congratulations to you and your success and your show for highlighting such important issues. Thank you for having me.
Well, thank you, Dr. Guerra. I agree with everything you said, except for one thing. I don't think you should be embarrassed. I think you should be empowered because you are an inspiration to women and men all over the world. And this is a global podcast. And I want to know that little girls from Nigeria, little girls living in India, they can look onto you and say, I can go ahead and get educated and I will be recognized by my industry and I get to do really impactful, revolutionary work. So thank you for all you do.
Thank you.
Great. So I always start the podcast in the same way because why change it up, right? And so my first question to you is, what is your definition of scientific innovation?
So for me, scientific innovation is taking creative ideas and then developing them and then implementing them into a way that actually brings demonstrated usefulness or value and then if possible, testing them to assure, we can't forget that step, to assure that we prove that they indeed are useful. And then finally, because I'm a scientist and you're asking about scientific innovation, I think of innovation as really targeting either the prevention or the diagnosis or the treatment of a disease, with the goal of either improving survival or decreasing morbidity and improving quality of life. So I think I would couch it in those terms.
Wow. I mean, I think that it shows your brilliance as a physician, as a scientist, because everything you do is through the sort of patient-centered lens. So thank you for incorporating that in your definition. Brilliant. Now, you were born in Honduras and you grew up in New York City. At what age did you identify your interest in diversity and inclusion? And how has this interest shaped your leadership mantra as a physician and educator?
Thank you for that question. Yes, I was born in Honduras, and I came when I was 3 years old to New York City. I came to Queens. My family left because they, like many others, wanted access to better opportunities. And in particular, the thing that I heard a lot when I was growing up was opportunities for an education for me, something they had very limited opportunity for. In Honduras, the compulsory education is up until the 6th grade when they were children, and that's been expanded to the 8th grade. So the population is literate, they can read, but obviously that's a very limited education. And so from the very beginning of my time as a child in the US, I knew and carried that weight on me that I had to seek an education and use that education to perhaps help myself and my family leave, the poor circumstances that we were in. We were at the time, had poverty. We were living in poverty, no insurance. I didn't know what a dentist was. Saw my first doctor when I had to go to medical school, and I had a form that I had to fill out that said, you need these vaccines. And so all the vaccines I had were through school. And so being a product of that experience, I think taught me one thing, and that was that the opportunity shouldn't depend on the color of your skin or where you were born or your gender. And I think that's where that seed that, made me pursue all the diversity and inclusion and health equity work that I've been privileged enough to pursue, that's when it was planted. So I would say at a very young age, from, the time I started kindergarten in this country.
Well, I was born in Nigeria, and I can tell you that growing up, I really saw what it means to live in a medically underserved community. And that's part of the reason why I launched a platform like this, so that people can learn about innovation, but also the importance of making sure that all patients have access to care. Because as you beautifully say, the opportunity should not be dependent on the color of your skin, right? Or where you were born. It should be that all patients everywhere have access. So thank you so much for that beautiful story. So my next question for you, obviously, is based on what I know, and I'm really impressed by your knowledge of structural inequities. Can you tell me more about the work that you're doing to reduce physician bias in cancer clinical trials?
Sure, absolutely. Yes, the structural inequities in cancer clinical trials, when I think about them, you can categorize them in 4 different buckets, I would say. So the first is the structural inequities that affect patients, the structural inequities that affect the trials themselves and who they serve, and then those that are embedded in the system, and then the physicians that practice in those systems. So if you want to go through those, we can talk about the patients first. So I would say the structural inequities that affect patients' access to clinical trials have to do with the proportion of uninsured patients that we have, the minority of whom are Black and Latinx. 11.5% of Black populations do not have insurance. This is pre-pandemic statistics from Kaiser. And 19% of Latinx also don't have insurance. And so if you don't have insurance, you're less likely to be able to access screening and cancer care, and may not show up to the system until it's quite late into an emergency room. And so that affects your early access to opportunities to trials. We have laws, as you well know, that help cover clinical trial expenses when someone has insurance, but we don't have a means to do that for the uninsured population. Then I would say another patient structural inequity is that even if they have insurance, a lot of the insurers have policies that prevent them from accessing the places where there are more trials, or even, perhaps restrict them to only going to places where there aren't trials, the options of trials, through deductibles and other copays. I have patients that will not seek care at our hospital, for example, and will go to a local hospital, a community hospital, because it's more expensive to access the University of Pennsylvania. So that's one problem. And then finally, the last one for the patients is the out-of-pocket cost. So even if you have insurance and you participate in a trial, there'll still be out-of-pocket related costs to participating in a trial, whether that's travel or childcare or so forth. So that's the patient. And then when I look at the trial-related structural inequities, this has more to do with what trials are being offered and where are they being offered. So I would say that it's not very common that systems or people who offer clinical trials, organizations, actually do a real analysis of who's in their communities and what cancers are they being diagnosed with, what cancers are they more likely to die of, and what are the disparities, the racial and ethnic disparities in that community you serve. And if you don't know that, if you don't know this catchment area, then how are you designing trials? Maybe it's what you find interesting, or maybe what, the pharmaceutical companies are approaching you to do. But the question I'm asking is there a true match here so that you're serving the community's needs? So I think that in itself could be an area that we could improve by understanding the catchment area. And then where are these trials being offered? Are they being offered in the large cancer centers, which are 2 hours travel away from you? Well, then, there's a structural inequity that we could also potentially improve by decentralizing access to clinical trials. And to do that, that means that those who fund and design clinical trials have to work with the organizations where you serve individuals who have the conditions that you are highlighting in your clinical trials. So you partner with those organizations, you partner with those physicians and help to decentralize that. And then digital access, I think that's going to help, and especially in the era of COVID, that's really, catalyzed decentralization of trials. There's all kinds of digital tools that are helping investigators not only recruit, but continue to obtain participant data, such as ePro data, and complete the trial with these digital tools. So that's the clinical trial component. I would say one more clinical trial component that comes to mind is, I know that ASCO and Friends of ASCO and the FDA have been working hard on modernizing clinical trial eligibility criteria, because that is a structural inequity. If you design trials that have as an exclusion criteria comorbidities, well, that's going to hurt minority communities most, because they actually have more comorbidities than non-minority communities. And there was a study that showed that 60% of trial eligibility exclusions were due to comorbidities and functional status. And so, this wonderful modernization that, as I said before, ASCO, Friends of ASCO, and the FDA are trying to do with new guidelines to allow us to remove some of those functional status and comorbidity ineligibility criteria will also be a way to help increase access to underrepresented populations in trials. So those are the first two. Then there's the system, and the systems, as you know, are incredibly complicated. But I think that it all comes down to one important thing, and that's that we know that if we offer clinical trials to patients, many of them will participate, if not most. But the problem is that the decision to participate often is not offered to them. And so creating a system where that is automatically the case, where each patient gets offered a clinical trial, an opportunity to participate in a clinical trial, is absolutely important. And if we don't do that, the way many centers aren't doing that, then what happens is then it's left to the provider. And that now gets to the final structural inequities and what you started out asking about. So the providers are human, like everyone else. They have an unconscious bias. And I have spoken to providers that to try to understand those unconscious biases when it comes to clinical trials. Those unconscious biases result in them not offering clinical trial participation to some minorities, Black and Latinx communities. And when you ask them why, it's really interesting. I think what it is it's their good intentions are subverted by their unconscious bias. So they may not offer a trial because they may not want to burden, put additional burden on communities that are Black communities, Latinx communities, who might already be burdened by the inequities in the social determinants of health, and now by this cancer diagnosis. So some of the thinking that I've heard them say is, I know that a clinical trial might pose additional transportation needs. They have to come to the clinic. They have additional paperwork burden, and they may have literacy issues that might prevent them from being able to participate and certainly complete a clinical trial. So, and then caregiver, that's another burden that they're concerned about. Oftentimes, they worry that participation in a clinical trial will also mean more caregiver burden to a family that's already maybe stretched, or a patient who hasn't had caregivers come to their appointments. And I think in retrospect, when we have these conversations, many of them say how just talking about what they've been thinking and analyzing their own practices has been eye-opening for them. Many of them have asked if that's my intervention, and it wasn't. I was just really trying to understand how they approach encounters when the race or ethnicity of the patient differs. So those are the four places where I think we have inequities and where there's opportunities.
Thank you for that very comprehensive response. I completely agree with you on so many aspects. I wonder if the inclusion of providers of color in clinical trials might help to sort of reduce some of the trust barriers and some of the sort of lack of knowledge about these clinical trials. What are your thoughts on that?
Oh, I think you're absolutely right. I can tell you that despite me being and working in the field for almost 25 years now of trying to understand inequities and designing programs to help overcome those, I can tell you that despite all of that devotion and devoting years of my life, that if I walk into a community and ask for their partnership to overcome barriers to either cancer screening or cancer clinical trials or cancer treatment, the response will be different than if it is if that same ask comes from someone who looks like their community, right? I can tell you because I have staff, employees who work with me, who come from those communities and who have instantly and immediately gained the trust of those communities. Like any other smart person, what I do is if they have the trust of the community, then I just empower them. and
Right.
give them all the resources and give them all the knowledge that they need to make that connection with the community and build programs with the community's input so that we can all get to that shared and mutual goal. So I've seen it. So you're absolutely right. We just don't have enough of a workforce at the moment that looks like the communities that we try to serve that could much more easily establish trust. And that's going to take a lot of more long-term thinking, you know, and oftentimes that's not what people are asking for. You know, they want to see results now and they want to see their ROI for whatever they're investing in. But this type of ultimately, this type of change will take years because we have to start when people are younger and not even thinking about a career in medicine, plant the seed, or a career in clinical trials work, as a pharmaceutical a company employee that works on clinical trials. We have to start early with the introduction of STEM and increase access to good education, and that can take years. I have to say some are starting to do it. I saw Bristol Myers Squibb recently put out an RFA for Genentech is another one for medical students to help them explore careers in research. And I think that's a wonderful population to start, although again, we're limited, right, by the pipeline at that level. We may need to go back even earlier. Otherwise, we're all competing for the same workforce individuals, and there's just not enough of us to really make significant change.
Yeah, I couldn't agree with you more. I know that the Alliance for Regenerative Medicine, they have their Grow RegenMed internship program that is also specifically to recruit Black students so that they start to get into the sciences a lot earlier, because to the points that you made earlier, if we cannot include people of color in the dialogue, then how are you going to find solutions that are sustainable? And I think to your point, that's why these issues continue to recur, because we, in many ways, we haven't really gotten to the root of it. We think we understand it, but there is such a lack of information exchange from the patients to the physicians to the pharmaceutical companies. It's really very complex. And I guess before we move on to the next question, I'm just curious to know, if you had I guess, a timeline, what do you think it would be for maybe a 50% or so increase in clinical trial diversity? When do you think we're going to have more robust data that showcases the differences in efficacy and safety for, say, an African-American patient related to a white patient or even a Hispanic patient? What are your thoughts on that?
Wow. Predicting the future timeline. I would say that, you know, there is a lot of wonderful momentum right now. I mean, you know, the fact that we're talking about this is an example of that. What I'm seeing is a lot of momentum from both the pharmaceutical industry that's always been engaged, but I feel like people are doubling down on their commitment and engagement. Stand Up to Cancer, organizations like ASCO, AACR, I mean, everyone is united and has made this a priority. The National Institutes of Health, they have also made this a priority, and they have established mechanisms in the programs that they fund to assure that we have thought about and submitted a plan to provide the equitable access to cancer research. So I feel that even though I've been in this, as I said before, for a couple decades, the amount of momentum that I've seen in just this year alone, and it probably was catalyzed by the larger society, right? And the changes we're seeing there after George Floyd. So I'm excited because I would have said, oh, you know, maybe 10 years, you know, we might see the changes. But I feel like, wow, this is an opportunity that might result in some real change, maybe in the next 5 years, where we'll see, you know, our enrollment by underrepresented minorities increase, you know, to represent the larger society. So I'm encouraged and I'm enthusiastic and hopeful and optimistic.
Yeah, hope and optimism is such a critical component to the work that we do. If you take that away, I think it's easy to sort of get depressed and sort of weighed down by the enormity of some of these issues, correct?
Correct. You said it. No, we have to remain hopeful. Otherwise, you're right. We won't invest in this as a real dream. We'll just give up
Right.
prematurely.
Right, right. And, your work has shown the positive impact that religious leaders and peer-to-peer education play in building trust and driving sustainable behavioral change. Can you provide a top-line overview of your work in this area and how it ties into this whole concept of sustainability?
Yes, and it ties into hope and
Yes,
optimism, as you were
yes.
saying, because I have worked with the Black churches in and around Philadelphia, and the Black churches have been a beacon of light and hope to communities, even in the type of darkness that we're going through right now. Yes, I think the Black church leaders are not only just sources of hope and spiritual comforters, but in today's terms, they are actually influencers of other people's behavior. So, and they know that, and it's a great responsibility for them. And so working with them, we have, for example, a partner, Enon Tabernacle Church, that has the largest Baptist church in the Philadelphia region, and it has a congregation size of over 16,000 members in 4 states, and they are just among our most treasured partners because they also, like you, are very focused on innovating and using innovation to provide opportunities for their communities and also opportunities for better health. And so we've been working with them for almost 10 years now. And, they are so instrumental in being equal partners. So we meet and we are co-leaders in designing opportunities, events, strategies. I'll give you an example. So as everyone knows, during COVID, cancer screening rates dropped precipitously. Breast and colon cancer screening dropped about 90%.
Wow.
Ned Sharpless of the National Cancer Institute did an analysis, and in that analysis, using modeling, he showed that given those rates of decreased cancer screening, that we can expect to see an increase of 10,000 new cases of cancer over the coming decade.
Wow.
And so when we all read that, we all obviously became alarmed, and so then Chadwick Boseman's death happened, which also sent shockwaves through our communities. And I remember getting on the call, and Reverend Leroy Miles, we talked about this, and he wanted, I could sense the urgency of wanting his community to have access to a way to diagnose colon cancer in his community. And so what we did was we innovated, again, there's that word. And what we did was, we knew we couldn't usually do the usual colonoscopies in the office because those had been canceled in order to send those providers to take care of COVID patients, to minimize exposure to other patients and so forth. And so we did a drive-by distribution of FIT tests, fecal immunochemical tests, which are stool tests that identify blood in the stool, which could be indicative of an early cancer. And so in his church parking lot, we are able to accommodate hundreds of people, and they've been doing this because they've been distributing food and school supplies during COVID. And so we held a drive-by FIT and flu shot day on October 31st. And so people would drive up in their cars, and there we were, our volunteers from Penn Medicine and Einstein. We would approach our patients that drove up and explain what a FIT card test was and give them the FIT test, and then they returned it to us. So there was, an opportunity for us that we took to change what the destiny is or was, which is, we're going to see 10,000 new cases in the next decade, and stop that prediction by handing over, by doing this program. And so far, we've handed over 100 tests and have gotten back about 70%. And of the 70% we've gotten back, we have identified 11 now positive FIT tests, so individuals that need a further workup for colonoscopy. And perhaps, you know, we might discover colon cancer in an otherwise time that we wouldn't have. So all this to say that religious leaders partnering with other providers of healthcare, of opportunities to participate in trials is a wonderful way. And if you build it, people will come. And so that's been a really wonderful strategy for us to be able to deliver healthcare and produce behavioral change, you know, in people that, you know, wouldn't have gone to maybe get a colonoscopy even without the pandemic. And so, and you know, at the time also, we capitalized on that on very unfortunate, very premature death of someone that many people looked up to and was considered, you know, such a talented star in our community. So, so that's just one example. And similarly, we work with them to host programs related to clinical trials and provide those opportunities to open access to community members to trials. And then one other way that we've also worked with them and are designing now is a peer-to-peer educational program where we're going to ask for individuals who want to be trained in clinical trials, who are from the lay community, who have perhaps had cancer themselves or participated in a clinical trial. We're going to take them through a curriculum, and the curriculum is called the Clinical Trials Ambassador Program. And they will become ambassadors once they acquire the knowledge of how to talk to people about clinical trials, how to help them identify where to get more information about clinical trials, and how to access those opportunities. And this came because one of the things we noticed was that when patients go and see their doctor that have been diagnosed with cancer to talk about the possible treatment, one of the things we noticed was that we give a lot of information to our patients about cancer treatment and clinical trials. And those appointments are an hour long. As you can imagine, there's a lot of information, and it can even be a little bit overwhelming for some patients. You know, I trust that all oncologists, many of them have very high levels of emotional intelligence, and they would know if a patient seems overwhelmed to step back and, you know, provide a little bit less information and review what's been covered. But even with the wonderful, you know, physicians that we have and their wonderful bedside manner, many of them come out overwhelmed. And you know what they were doing? They were asking our staff what they should do for their treatment. And so we recognized that they wanted and needed perhaps a layperson to help them review all the different possibilities. And these were medical assistants that were rooming them and taking their blood pressure, and then they would come out and they would talk with them. And so that gave us the idea that maybe there is an opportunity here to train other lay people as ambassadors of clinical trials to help increase awareness and help support our patients.
I mean, I think I should clap at this point because I'm really blown away by sort of the comprehensive approach that you take to your work and how you measure your work by impact. So it's not just like, oh, let's check the box, we've done it. Chadwick Boseman in particular, his death resonated with me as well. I actually wrote a piece on Entrepreneur where I highlighted some of the challenges within the African-American community where, for example, a mistrust, a fear, almost an aversion of medical professionals leads to lower screening rates for diseases like colon cancer. And so when African Americans get colon cancer, it tends to happen at a younger age. Like Chadwick was, 43 years, 44, not even 44 years old. And it tends to be much more aggressive because these cancers are being caught at very late stages. So I love the idea of, you know, sort of early detection, because obviously that's going to be critical to coming up with a clinical intervention that will help these patients to live longer, healthier lives.
And I'm so glad you brought that general fear of healthcare. It is something we face. It's iatrophobia. It has a name, which I recently discovered, iatrophobia. It's the fear of healthcare or healthcare provider. We see that a lot in our communities, and it's because our many community members think of healthcare as a place you go when you're sick. And they're not used to thinking about a healthcare as a place to go when you feel absolutely fine. And when you feel absolutely fine and you go to your doctor, the doctor is going to spend the entire time talking about prevention. And so it's an interesting, very tangential or very cultural, perhaps, way of thinking about how to use healthcare that you pointed out, which we also struggle with, and try to break that paradigm and try to teach a new paradigm.
Yeah, and I think it has a lot to do with the Tuskegee syphilis study, the Henrietta Lacks debacle. So much of what you hear about, and is very much amplified, are things that are quite negative. And I love the fact that you have this sort of grassroots approach, that we are going to talk to you directly. We are going to partner with people that you trust, like your religious leader. And that is a starting point. I don't think there's a perfect solution, but I'm just glad that you're doing everything that you can to get access to patients so that we can identify this cancers at a much earlier stage. So thank you for that.
Thank you. No, and that mistrust, sometimes I hear stories. I was listening to a lecture last night by the author who wrote Medical Apartheid. She's a Rochester graduate, and you mentioned I went to Rochester, so I was invited to that. And she told, Harriet Washington told the story about how she had developed a mole and went to see a white dermatologist and said, I'm just worried about this being skin cancer. And the dermatologist said, oh, Black people don't get skin cancer.
No.
And she was taken aback by that, by his inaccurate knowledge of a disease in Black populations. And so, there is a lot of still mistrust, and it's not just the well-cited, studies that you talked about and experiences that you talked about, but people still experience, cases of in the office with physicians that lead to some mistrust. And I would just say, if that happens, I tell my patients, yes, you should leave that office and you should
immediately.
Exactly.
Right.
Exactly.
Immediately. The empowered patient is one that I'm looking forward to. And I think there is so much information in today's world that is available at our fingertips, literally, but also being able to trust medical professionals like yourself that have gone through very extensive training to get to advise patients. I think it starts first by listening, paying attention to what is being said, and trying to personalize the care to the patient versus trying to sort of make those general broad statements like, oh, Black people don't get skin cancer, so you don't need to put on sunscreen. You can just go out there, you have melanin, and you're going to be okay.
Exactly.
And that's not true.
Exactly. No, that's well said. Well said.
Great. So in closing, do you have any final comments or thoughts? Anything that you think you want to add our audience should know before we wrap up?
Only that, I think you've heard me say this before. I think clinical trials represent a tremendous opportunity for all of our patients, but also for advancing our humanity and humankind and progress. And so I think that given their importance, it is absolutely vital that we educate ourselves, that we educate our communities, so that everyone has that option to participate in research. And so thank you for highlighting that and the importance of that. It's people like you that really help us in that mission, and for that we are so grateful. Thank you, Sophia.
Thank you. The feeling of gratitude is mutual. You're out there dealing with patients all day, and your passion, your devotion, but perhaps most importantly, your humanity is one that is pretty obvious to anyone who watches this, because they can see it for themselves. So thank you for all you do, Dr. Guerra.
It's my pleasure to be here. Thank you so very much as well. Thank you.
Thank you. All right. I look forward to staying in touch, okay?
Likewise. Thank you.
All right. Now, bye.
Bye-bye.